So just for a moment, why don't you just go back to that thing we were playing with yesterday, just thinking of your foot and moving at the ankle, and you're just lifting the forefoot and then reaching it away. And as we all kind of know, our heel is behind our lower leg bone. So just like in the ATM where Arlene was guiding you to think about the direction of the heel and then think about the big toe and then the pinky toe, it sort of fills out that map. But if we're just looking at that motion of the heel reaching away from the head or reaching back toward the head, so this is what we call purely a sagittal plane action. It's just flexion and extension. Yep. So this happens at the highest point of the foot. So there's a joint here between the tibia, the fibula, and this amazing little bone right here called the talus. That's this bone here, and you can see that beautiful arc that it has at the top, and you can imagine the tibia moving over it. The funny thing about it, I don't know if this is too much information, but the back of that bone is narrow and the front of that bone is wide. Do you see that? If I take it off like that, can you see that the back of it is kind of narrow and the front of it is wide? So what that means is that when my heel is reaching away, you're going toward this wide part of that bone, and that actually assists these two bones to actually have a little bit of separation, a little bit of space more. And then conversely, when we reach the heel back up toward the head and the toes away, we're moving to the back part of that bone, the talus bone, and that's narrower. So the fibula actually comes a little closer to the tibia. So you can think of bending this way, which would be as if you were going to go down or lean forward. There's a kind of a space opening, and then as you go back or you lift the heel like we did in the ATM yesterday, there's a kind of a narrowing, there's a kind of a togetherness of those lower leg bones. Now, as you rest there, if you're just lying there, your feet, generally they'll flop out. They may still stay kind of flexed, but for most of us they'll lengthen. Or the toes will reach away a little bit. So that is a resting foot. That's a foot that's maybe being picked up, about to take a step. But when we actually are standing on our foot actually has to come into that more perpendicular relationship to the lower leg. And so we have not necessarily all the way, so it's not fully flexed, but it's more or less in that perpendicular arrangement. And so here, we can create that situation by working with these bones, these small bones in here. These are called our metatarsals, the longer bones. Michelle likes to call the pads, the pillows of the toes, the very end of the toes. You can see you've got 3 bones, except for the big toe that's got 2. But those are just like your fingers. There's 3 bones in there in these. And then we have these metatarsals. And then there's this incredible compact series of bones at the back, which actually, and I think I covered this on last September where I talked about we can turn in those bones. The toes rotating this way and that way requires movability back in here. And so to organize the foot to be standing, the big toe has to actually come down a little. The pinky toe has to go up a little. And there now I have that foot arranged in a standing position. So if your foot is laying on its side, if you think of the base of the big toe reaching away and then bringing the heel also a little away, then you arrange your foot to be in a standing position. And then from there, we could look at what's going on in the hip as well. From when that leg's gone from this position where it's resting on the side. So you can see up here the femur head, the ball going into the socket. Now, and if I raise that lower leg a little bit, now the way the knee relates to itself, there isn't going to be turning in the lower leg. If the lower leg is straight in relation to the thigh bone, then as I organize this foot to be standing, there'll be a motion happening in the hip. And I think you all felt those motions in the hip in that ATM as you were turning your heel in and out. So as I rotate this leg into the standing position, I'm also repositioning the ball into the socket. See that? Does anyone have any questions so far on all that? Sure, I can do it with the other foot. So you can see it. Well, okay, so I'll just repeat the little sequence. So first, the technical word for this, you don't have to know, but just know that you've got this. I mean, if you want to know it, you can. You can study that stuff. But there's a big curve in here, and then it's the tibia, the main weight-bearing bone in the lower leg, sits right on top of that dome. And then the fibula, this bone that's on the outside, it's sitting on, it becomes the outer ankle. And that sits there as well, next to that bone. That bone is the talus. I brought this foot in, which you can play with. It actually comes apart, and you can, these are the toys that I create. So, but that's a really cool way to look at that bone, and you see that beautiful dome there, and that your lower leg bone is going to move back and forth over that. Okay, so we want to actually, from that foot being the toes reaching away and the heel being back toward the head, we're going to actually reach the heel away, bring the toes back up toward the head, and then organize this situation so that the big toe could actually be more parallel to the floor, if you imagine the floor there. So I've organized the foot there, and as I do that, if the lower leg is up in line with the upper leg, then it's going to create that turn in the hip joint. Do you see that? And so that's going to approximate a standing leg, as if you were to be standing on that leg. Does that make sense? Okay. Anyone else have any questions?
So they're going to practice this?
Mm-hmm. So it'd be good to, and you'll feel that with your partner, not this plastic skeleton, but there'll be a different affordance for this, reaching the toes away and then reaching the toes back toward the head. One foot maybe is happier to go back in that direction than the other. And then also this organizing the foot so that it's standing. If you imagine that board being able to meet, the points of the base of the big toe, the pinky toe, and the heel, all in one organization, you're kind of thinking about creating and simulating that position and seeing how, well, we're not pushing through yet, right?
Yeah, but just...
Do you want to give Ellen that mic? Yeah.
Okay. Well,
I don't think it's on.
One of the things I've observed sometimes when people learn artificial floor is that, if you could mime this for us, is that they're too busy with the foot trying to get something, and they're not thinking high enough up, and so they torque actually. Can you torque the knee a little bit for us?
Yeah.
So they do something where they put pressure on the knee. So, yeah, you kind of recognize that a little bit? This is usually the first pass at it. So that you don't get high enough up. So repeat what you said about, so if you're talking from the standing foot into the hip joint, you're high enough up.
Yeah.
And this knee is safe. But what did you say? You don't want any relative movement at some point you take out the relative movement in the tibia and the fibula. Just repeat that, because I think that's going to be important.
Oh, this bit here, down in the ankle? you mean?
Once you said once you organize or sort of arrange the foot as a standing foot, then
Once you want to organize these bones in such a way that you've actually got this foot perpendicular. There isn't any slack, there isn't any play in here, and I've got everything compacted, so that now as I move my whole self forward, the force is going to transmit up through this and cleanly into the hip. If the knee is bent or twisted in some way because I've over twisted the foot or done if I've tried so hard to get it there, I might have now created a bend, and now when I push, that's not going to go through here so well. It's actually going to get trapped in here. So the thing about our knees is when you bring the leg to being straight, it's like when you're on your back and you had your legs up. If your knee is bent, you can actually create relative movement in the knee itself when the knee's not straight. But when the knee is more approximating a straighter position, then the movement will transmit through the knee up into the femur bone and then up into the hip. Okay, so you want to, and you don't want to go so far. Some people in here have so much movement that they actually go past that place too. So you don't want to lift the foot so high that it's already doing that too. The roller is here to support the upper leg, and you just bring it to where it feels like, okay, that's it. I've got to the place where it feels like it's together. And now you'll confirm it by, if the minute you move that foot, you will see the movement transmitting up into the hip joint.
You can do it in small groups.
Yeah.
So you haven't done this, right? You went straight into doing it with the board. So you haven't done it with the hands, or you have?
No. I think we did just turning the leg out. Do you remember? To draw up the knee. We did that, but we didn't do this yet,
Okay.
I don't think.
All right. Does that feel like enough of a piece to practice after lunch in small groups? We won't do the inner and outer edges of the okay.
Yeah. But we can, I mean, you want to get the feel for where are you holding, what are these places, and we'll help you with all of those details.
Small groups so that you'll know who your person is, and it'll be a little less chaotic, I hope, of these people. I don't know what. So we'll do the A's, the B's, the C's. I'm all about the B group today. No, the back of the B group. I'm all about the back.
Back.
Yes, there's a ligament here between each of the spinous processes. There's also one on the side. There are also muscles. The interspinous muscle is the muscle that goes between these spinous processes.
But there's no separation between the back of the vertebrae and the front. You say the front, there's a disc that's a synarthrosic
there is.
joint, and
yes,
the back can move?
There is. Okay, so okay, that's a different question. So if I could pull one of these out, I would show you like an individual vertebra, and I have slides and stuff to show all that. But if you want to see that here, I'll show you on the lumbar spine. Not a very nice thing to do to this poor skeleton, but anyway, this is our vertebral body. We have a little connector from the vertebral body to the transverse process. That's called the pedicle. That's called the foot. And that is technically, when you enter the pedicle, you're now talking about the vertebral arch, which is all the back structure where the spinal cord runs through, and the transverse process, the spinous process, and then there's this place that many of your Feldenkrais trainers will talk about, the lamina, this gutter that runs between the transverse process and the spinous process. Are we having two conversations? Sorry. Okay. All right. Cool.
So is it a separate joint in front?
No. This is all. No, it's all one connection. I haven't got to the facet yet, but the vertebral body, the pedicle, the transverse process, the lamina, and then the spinous process. But between that, we've also got the facet joint. So we're going to talk about the facet. That's where the joint is. If I had a separate vertebra, I would show you that individually. I could draw it on the board if you like. But this is, huh? You want to see the facet. So I showed you, these were the facets in the neck, right?
now we're coming into the region after C7, which is the big vertebral prominence that you feel. For most of us, it's the big bump at the back. If you spread your fingers like this from the big bump and upward, and then you do this pecking motion, you'll feel that the neck articulates. Those spinous processes go forward. And if you're low enough, then you'll feel one that doesn't go forward. That's probably T1, the first thoracic spinous process. Okay? So, from the thoracic, now we're into the thoracic spine, huh?
I've never felt that.
I know, and it's an amazing and easy way to kind of feel it. And if you do the lapping lessons, there's many lessons where we actually articulate these actions. And it's great to feel that difference, so that when you've got your client, student resting on the table and you're lifting their head, you'll feel the differences when you're working in their neck versus, oh, now I've got their whole chest. Now I'm feeling that first vertebra. So now that we're into the first, the area of the 12 thoracic vertebra, the facets in this region go from, say they've been, Joyce is gone, but that's okay. So say they've been here, sorry. Okay, so here, they've been here in this sort of more horizontal plane. Now I'm just going to show you front and back. Then they're going to end up more facing this way, facing the front of the room and the back of the room. So this is called our secondary plane, that red plane there, which is the vertical plane. So it's kind of, that's an abstraction to just say the plane. But if we think about this, and these are the way these facets join, I'll try to open one up to show you. So here I've opened one, I'm going to just slide the card in, but you imagine that now it's facing the front. So if I've got this orientation, I can actually bend to the side. One will slide close. If I'm bending to the right side ones will come together, the left side ones will separate. Yeah? So I can do that. But the other nice thing about this plane is that they can slide past each other this way. So when I rotate, when you are helping your person with their arm, say you're going to just put, when you're turning them this way, I'm actually sliding one facet joint over the neighbor in that rotation movement. So they're turning. So if I could just show how these are moving, so if you're turning that way, the facets on the right side are actually going like that. They're separating on that side. They're coming together on the left side. And now if you side bend to the right like that, so now they're pushing together, and now side bend to the left, now they're opening up because of the plane that they're oriented in. Okay? Everyone clear on that? In the thoracic spine. So in this region. Of course, you can't go rotating wildly there because you've got a rib connected to that. And the rib comes to the front. So when I rotate, there will be some limitation because of the movability of my ribs or lack thereof. Okay? So that's somewhat a limiting factor in the rotational movement. But you can certainly flex, you can separate these, and you can extend. But it's in extension that we now run into another limiting factor. And it's not the anterior longitudinal ligament here. It's actually these spinous processes. When you go into an extension, chest moving and opening, my spinous processes run into each other in the back. And at best, this section of the chest can only go to straight. It won't really go into a, you might feel like you're doing a whole bowing arch thing, but at best you're going to a straight line in that section. Now we move into the lumbar spine, which is the lowest part of our spine. There are 5 vertebrae there, and these, the facet now changes from this frontal orientation to being in this orientation. Now these facets, the way these guys intersect with each other, is in this, what we call the sagittal plane. So this allows your lower back to be able to arch and to round. And that's about it, because when you twist, so if I'm twisting, what I'm actually doing, and you can see this in the camera, but you folks might not see it. I'm going to show that side and then I'll show it to the back. When I twist the pelvis to the right, say I am pulling the right knee forward and pushing the left femur into the hip joint, I'm doing this rotation, which is going to lock all the facets on the left side. It's going to make a tiny little gap on the right side, but because they're in this orientation, they will only move approximately 1 degree, each of them. 1 degree and a full circle is 360, so you're thinking 1 degree, so all 5 of these vertebrae are going to give you a maximum of about 6 degrees of turning. The minute that's happened, once I have pushed into there, so I'm going to push into I'm going to do what I'm doing with him, so once I've done that, 6 degrees, when her pelvis has turned 6 degrees, now the movement's going to go into those thoracic joints. So that's why I think supporting the arm and turning them and then coming back to this really plays into following along the journey of these facets. You don't feel that, but that's what you're doing with the spine and how it's relating to itself. So there's the twist. And so I'm going to turn that to show it to the back. So if I'm turning my pelvis to the left, I'm going to lock all the facets on the left side of the lumbar spine and open the ones on the right, but only minuscule, a small amount. So I'll show you that to the back. So you see on this side they're opening, on that side they're closing. Okay, and then the movement, so a lot of movement is transferred very rapidly into the lower thoracic spine, the area that we talk about as the floating ribs, the ribs of breathing. So the freedom and the capacity to move freely there is an important part of how you might walk. If you move your pelvis considerably more than 6 degrees, you're going to need that movement going up through your spine. There's a little more to say, like how does it transition from the thoracic to the lumbar? Well, at one vertebra, you have a 90-degree shift. So at T12, you have the top facet is like a thoracic facet, and the bottom facet is like a lumbar facet. So there's a 90-degree difference just at one of these vertebrae, and that's it right there, right where the 12th rib connects. So if you want to look at that, the floating rib connects to that. If you want to look at that at some point on this skeleton or on the other, you will see this incredible 90-degree shift, which is quite an amazing mechanical transitional place.
That's where the diaphragm is as well.
The diaphragm connects all along your 12th, 11th, and all along what's called the vertebral arch, which is all the not vertebral arch, it's got another name. But anyway, along your costal, the cartilage is at the front as it comes down like that. So if you stick your fingers just underneath your costal cartilage at the front, you're touching your diaphragm and all of your abdominal muscles there too, actually. Question, yes, microphone?
So does it make that specific area more fragile, the part where there's a 90-degree
No,
shift?
I think we have, I don't think it makes it more fragile, but if you're working with somebody and you're thinking, why is this stuck? When I go past this vertebra, why is there no turning anymore? Well, it could be that you've already transitioned into the lumbar spine and you shouldn't be expecting turning. So somehow the structure could help you understand a little bit of it.